we go to thoracic. In thoracic, rather than doing cause-wise, now I'll teach you pattern-wise because everything will have an overlapping pattern, right? So lots of theory I've written, which I hate, but I've just written so that it's easier for you to frame an answer. So lungs are among the chief target organs and kuch na kuch lung mein ho hi jayega, obviously. So what all do we have to think of? First, I'll tell you the causes and then we'll think of the pattern, okay? So bacterial infections are the most common. Same thing, pneumococcus, staph aureus, all right? PCP pneumonia, very, very typical, very important. You will not study PCP anywhere else. Mycobacterial, yes, but now we have to take into account atypical mycobacterium as well. This is important. Agar reactivation pattern, I mean, if the CD4 is good, it will be like secondary TB, right? Reactivation pattern. But if CD4 is less, it will behave like primary. Do you remember this from our TB lecture, everybody? Primary TB kaisa dikhta hai? So primary TB is going to have consolidation around the middle lobe and the, around the fissure, around the horizontal fissure. There'll be necrotic lymph nodes, effusion also, yeah. So primary is essentially consolidation and lymph nodes. Reactivation is essentially fibrocavitary changes. Okay? Then you can have Cryptococcus aspergillus, rarely CMV. Now the specific things start to come: Kaposi sarcoma, lymphoma, lung carcinoma also is in higher prevalence as compared to normal. Okay, so these are all the things that we have to study. How do they relate to CD4 count? So more than 400 में bacterial infection, TB, lung cancer. 200 to 400, almost the same with lymphoma coming into picture. Super important, once it drops, अब आपके पास atypical mycobacterium, PCP, miliary TB, CMV, Kaposi sarcoma come in. So they come in only at low CD4 count. Okay, so now I'm going to teach you pattern wise, that what pattern will you think of? What DDs? Pehla pattern hai normal. So when you have a normal chest radiograph, that's also, the manifestation of a lot of infections. So almost 40% with PCP because it's subtle GGOs, 14% with TB because there are nodules, random nodules in the early cases. Normal chest X-ray. When you do CT, you can you see that there are these nodules which are randomly arranged. So this turned out to be a case of tuberculosis, which was missed on the X-ray, right? So that is why in almost every HIV/AIDS patient, HRCT of the chest will be done. Okay, so that is something that you have to remember. The next pattern is, or the first pattern actually is consolidation. So what do you consider? So the most common cause obviously will be a lobar consolidation with a pneumonia, with S pneumonia being most common. TB fungal infections can come. And very important, if it is persistent, non-healing, rule out lymphoma and lung cancer. Yeah, bronchoalveolar carcinoma. So now the CD4 count in pulmonary becomes very important now, because every pattern now we have to think of different DDs. So look at this here. Can you see how there is a consolidation? Can you tell me which lobe this is involving? Right middle lobe or lower lobe? So you can see how it silhouettes the right heart border, yeah, and it doesn't silhouette the diaphragm. So this is a right middle lobe consolidation that you are seeing, very typical of S pneumonia. The CD4 count is also more than 400, right? So this was an S pneumonia consolidation. Obviously, microbiological evidence will have to be taken, but radiologically, this is a typical lobar consolidation. Relatively lower CD count now, 151, less than 200. And you can see this consolidation with surrounding GGOs. You can see another patch of GGO in the left middle lobe as well. So this actually, because it was long standing, this actually turned out to be a case of tuberculosis, right? So this is much like your primary pattern of TB, isn't it? CD4 less than 200 consolidation, we said, right? So this is your primary pattern of TB in relatively lower CD4 count. So what do you see in this entire page? It's way too familiar to you guys. It's all tuberculosis, right? So look at this. This is your primary pattern of TB. This is where primary TB usually presents, around the horizontal fissure. Yeah, so you can see how there is a right upper lobe consolidation, very, very necrotic mediastinal lymph nodes. So all of this is your primary pattern seen in relatively lower CD4 count, and look at this here. What do you see, everybody? You can see randomly arranged bilateral millet-shaped nodules, miliary TB, and in the same patient, you can see, your spleen also having these nodules. So this is hematogenous spread affecting diffuse organs, right? So miliary TB is your primary progressive TB, again associated with lower CD4 count. The third pattern is GGO. GGO, unless mentioned otherwise, will be PCP, right? So, normal हो गया, consolidation हो गया, GGO. GGO, think PCP. What else can we think? Viral, okay, like CMV. LIP can be there or NSIP can be there. So essentially PCP. So look at the variety of presentations of PCP. So you can see how in this patient there are very subtle GGOs, whereas here you can see a remarkable bilateral perihilar involvement, perihilar GGOs, right? So that is something which is very typical, and this can mimic cardiogenic pulmonary edema, isn't it? So you are seeing that there is no cardiomegaly, there is no pleural effusion. So that helps you rule out cardiogenic pulmonary edema. Yes, उसमें cardiomegaly होएगा, curly lines होएगी, pleural effusion होगा. We are not seeing any of that. When you see the CT, again you can see bilateral perihilar GGOs with some sort of interlobular septal thickening as well, but essentially GGOs, right? Next pattern is cystic lesions. Again, cystic lesions, the first thing that should come to your mind is also PCP. Okay, so you can see, bilateral thin-walled cyst. Can somebody tell me definition of a cyst versus a cavity? What is cyst? It has a thin wall, right? So what is thin wall? Very good. Any wall less than 3 mm. So it will have a thin wall less than or equal to 3, less than or equal to less than 3 mm. So they take less than equal to 2 mm. More in the upper lobes. Another pattern is LIP. Remember in our ILD class, we have studied LIP associated with AI, AIDS and autoimmune, right? So that is LIP, which is along the peribronchial distribution, and cysts may lead to pneumothorax. So look at this case. You can see bilateral GGOs, and then there is a large, usually it's not so large, but here you have a large thin-walled cyst. And you can see how that has resulted in a pneumothorax, right? So these cysts may rupture. This is the standard typical spotter of PCP that they can give you, where you see GGOs in the subacute stage. It goes on to develop these cysts, and the cysts keep increasing in size. Okay, so this is very, very important. So fourth pattern after cyst will be nodules. In nodules, I will teach you two things: micronodules, macronodules. So when you have micronodules, meaning less than 1 centimeter, again, it's basically centrilobular distribution, right? So you will think of all infections which come via endobronchial spread. You will think of LIP or follicular bronchiolitis. So basically, almost everything which is airway, endobronchial, or miliary hematogenous, which will be random. Okay, so follicular bronchiolitis, apart from RA, can also be seen in HIV/AIDS, right? So that's another important cause of follicular bronchiolitis. So look at this. What do you see? So CD4 count is more than 400. Acute cough. So what would you think of? So you can see there are just these diffuse reticulonodular opacities bilaterally on the X-ray. You can see how there is some amount of peribronchial thickening as well, right? And same thing on the CT. You can see there is peribronchial thickening. There are all of these nodules which are associated along the airway. What possibility do you want to consider here? Acute presentation hai, fever bhi hoga. So bronchopneumonia would be your first DD. Before you think of TB or anything, in high CD4 count, very good. Think of bronchopneumonia, bacterial cause like Staph aureus, gram negative, right? So this is bronchopneumonia. If the CD4 count is a relatively lesser, 220 hai, so now you start to think of, your atypical causes. So what do you see here? So this actually turned out to be cryptococcus. So you can see bilateral, reticulonodular opacities. You can see nodules which are again distributed in the tree bud appearance, right? So you can see how again there are these nodules associated in the centrilobular distribution. So this turned out to be cryptococcus, very, very non-specific. Same way here, you can see the tree in bud distribution, almost bilaterally you can see, some of which are also cavitating. And this turned out to be histoplasma, right? So histoplasma, completely mimics TB. So here, TB histoplasma would be your differentials, turned out to be histoplasma. So micronodular pattern, you can have bacterial bronchopneumonia, you may have TB, you may have histo, crypto, all of these mimicking. Okay. Macronodular, particularly, non-resolving nodules, now you start to consider lymphoma, CA lung, or infections. So this is a very, very low CD4 count, and there was this nodule. In fact, there were multiple nodules, right? You can see 2 nodules here. And when this was biopsied, this turned out to be lymphoma, right? There's also a nodule. So there are multiple nodules which, turned out to be a presentation of lymphoma, macronodular lymphoma. Another nodule, you can see higher CD4 count. What do you think this is? Look at the typical spiculated margins. Yeah, this turned out to be CA. And in HIV/AIDS, it's squamous cell, rather than bronchoalveolar, it's squamous cell, which is always more common. Okay. So this was squamous cell carcinoma. Look at this again. This could be anything, right? This could be squamous cell carcinoma. This could be lymphoma. So we will always do a biopsy here. More like still squamous cell will be the most common type. Okay, even though it has, an atypical morphology like adenosine. This actually, turned out to be cryptococcus. So you always biopsy because you want to rule out a malignancy. So this turned out to be a cryptococcus nodule, one nodule, large nodule.